Good afternoon. I am Christy Walker, Safe and Healthy Schools Coordinator for the Utah State Board of Education. Welcome to our Safe and Healthy Schools webinar series. There are a few items of business before we begin. For those who cannot participate today, a recording will possibly be posted to our Safe and Healthy Schools events and trainings page. One relicensure point/hour is available for participants who complete the required questionnaire, and the link to that questionnaire will also be posted on the events and trainings page. For 1 month, the close date will also be listed. There will be a question and answer portion at the end of the presentation. At that time, you may submit your questions in the chat box. We ask that you remember virtual meeting etiquette and keep your microphones muted. This is the last webinar of the series for the Safe and Healthy Schools webinar series for now, and we will look forward to seeing you at our Safe and Healthy Schools professional development in the 2021-2022 school year. By way of introduction, Kuhn Nugent currently works as prevention specialist for the Utah State Board of Education with a focus on restorative practices under the student support section. In addition, Kuhn works on dropout prevention and recovery program, coordinates absenteeism and truancy training, and manages the annual Do the Right Thing Challenge, a violence prevention initiative for 7th and 8th grade students. Prior to coming to USBE, Kuhn had 12 years of work experience focusing on coordinating and implementing juvenile justice policies for the Utah Commission on Criminal and Juvenile Justice Governor's Office. Marty Liccardo has been an anti-violence educator and trainer for over 22 years. He has extensive experience speaking, training, and providing programming in the public and private sectors. Marty provides in-depth and interactive presentations and programs. Currently, Marty serves as the community engagement specialist in the Violence and Injury Prevention Program for the Utah Department of Health. We'd like to thank our presenters in advance for their information, and we'll turn the time over to them.
I'm going to be starting today, and I'm extremely happy to be here with you all, and excited about the topic, and probably more excited about the discussion we're going to have at the end, because I think the material that Kuhn and I put together should hopefully provide a good foundation and framework for rich discussion, or at least further discussion on these topics. I'm going to start today just going through some concepts from the Department of Health on prevention of violence, but broad-based concepts that hopefully a new framing and a new lens to look at how we think about behavior and violent behavior specifically, and where it comes from. So we're hoping to hopefully, I always like to start presentations by saying as much as the goal here is curiosity, and the goal here is I want you to feel like you understand this topic less well than you did before we started. Like, I want you to have more questions than you do right now about what we're talking about. So I'm gonna, and I don't know if I have control over I forgot to ask you this before. Am I gonna have control over the slides at all? Oh, you're on mute.
I think Kuhn will just advance that for you.
Oh, perfect.
You're so say next.
Okay. All right. So why don't we we're collaborating for prevention, primary prevention, shared risk and protective factors, and community level approaches for a healthier and safer Utah. What is the framework behind, in a lot of cases, how we should be thinking about both prevention of violence, but also intervention? And we can move forward. One of the things that's important to understand is when we look at research on violence, we often see violence and think it's its own thing. It's just happening as a factor of life, when in reality, violence is often supported by risky behavior from unsafe or unhealthy substance abuse or overuse. Violence can be exacerbate issues related to diabetes and cancer. It can exacerbate issues of it can basically the way to think about this slide for time's sake is to say violence impacts all of these things, and all of these things impact violence. That violence doesn't happen in a vacuum; it happens in contextually, and it relates to a lot of other things. So part of it is understanding root causes, which we'll get into in more detail later. That the consequences of violence can be really, really bad, and they can be far more complicated than we think that they are. And we can move forward. We're going to talk about a public health approach and what a public health approach is. And that's the approach that the Department of Health takes. One of the reasons I like public health as a concept is because the public health approach asks us to not look at good behavior or bad behavior or good choice or bad. It asks us to say what is healthy or what is unhealthy. Is the choice you're making or the decision you're making or the behavior you're producing, is it healthy for you and the community you're in, or is it unhealthy? Because one of the things we want to start to do is destigmatize a lot of these kinds of issues, because when we destigmatize them, we take a lot of the cultural ickiness out of them, and we start dealing with, is this a good thing for your health or for the community's health? Is this a negative thing for the community's health? And we can move forward. We're gonna be talking about intervention and prevention because these two things are very, very different. And I'm going to spend a few minutes defining and unpacking the difference between prevention and intervention. I will say with a public health approach too, it asks us in some detail to evaluate whether a problem exists and what the problem is, to create interventions and prevention strategies or some kind of intervention for it, to apply that intervention and then test whether that intervention worked. And that's one of the things we want to do here too, is that you have to figure out how to test these things before you start them, and we can move forward. So to try and unpack the difference between prevention and prevention, I'm going to borrow Kamara Phyllis-Jones, Dr. Kamara Phyllis-Jones's model, because I think it's really, really good. And what she asks us is to say, this really simple drawing will give you a an overview of how to think about this, but it's a little more complicated than that's this drawing. But I like the simplicity of this. This was on purpose. Let's say you have, this is the cliff of health, is how she defines it, the cliff of good health. And on this top of this cliff, you have some kiddos playing at the top. And you're worried that some of those kids might accidentally fall off this cliff. So what we do is that those 3 pink lines at the top, we build a fence. And that's primary prevention. Build a fence because they can't fall off if there's a fence there. And keep them as far away from that fence as possible. The cliff of ill health is a bad cliff, and we want to make sure that nobody's playing near it. And if they do get near it, there's a fence to protect them. That's primary prevention. Then some of those kids are going to be little rascals, and they're going to climb that fence or play around near it. We don't always test out the structure of it, so we need to make sure that blue dotted line is a net, and there's a net there to catch those kids who happen to go over that cliff. So for the unfortunate scenario that kids go off the cliff with poor health or poor health behavior, they can be caught by that net. Now, over time, that net's going to get holes and weaken, and there's going to be problems with it. So just in case that net doesn't catch all those kids, we want to make sure that there's an ambulance at the bottom of that hill. And that's tertiary prevention, some kind of medical care intervention or services after violence or harm has happened. So all of those things are really, really critical, and we want to make sure that those things are in place. But prevention is preventing something from happening in the first place. Intervention is intervening when it's happening or after the fact to mitigate it happening again or the negative long-term serious consequences. And we can move forward. Now, Kamara Phyllis-Jones understands also social determinants of health, and that this is just not so simple as primary, secondary, tertiary, because for some people in our community, they are far closer to that hill than other people, okay, or the cliff. And for some people, they don't have a fence, they don't have a net, and they don't have an ambulance. And we know that there's a lot of people, probably even on this call, in communities in Utah, where those primary, secondary, and tertiary services are less resourced, or in some cases non-existent. so we need to not only make sure that those services are there, but make sure that they're there for all Utahns. And what does that look like at the state level, our responsibility, and what does that look like at the community level for making sure we're testing and addressing those needs? And one of the reasons I really like this is to say, like, it's not so simple as to create the services. We also have to make sure those services are being used and work and are effective in those communities. And that takes a lot of collaboration, which is kind of the goal of this presentation in general. And we can move forward. We use the social ecological model, which asks us to look at individual characteristics, relational characteristics, community characteristics, or what we refer to as domains. So it has 4 domains. This first domain is the individual, which is personal characteristic, biological factors, behavior. So what people do, individual people do, think, act, how they maneuver, and we can move forward. The second domain is relational. These are interactions between 2 or more people, families, friends, neighbors, peers, small group cohorts and groups. How do they behave, and how does health and health behavior work within those folks? We can move forward. The third domain is community. This is setting up environments, institutions, neighborhoods, schools, workplaces, church. So social relationships can take place here, but also community level standards and norms take place here. And this is a really important thing to think about. And then finally, the next slide is societal level. So large scale policies, laws, beliefs, norms, institutions. This is that level of like true cultural construction. And one of the things the socio-ecological model asks us to do is look at each individual domain of health and make sure that we're addressing those, because we should be helping individuals. So for example, with the topic today, we're talking about behavioral issues. We should be dealing with the individual and the behavioral issues that are happening and what's happening there, but we should also be looking more broadly at what are the policies, what are the beliefs, what are institutional arguments being made, so we can understand this more complexly. And the further up, we in public health refer to this as upstream thinking. So on this society level, we change a major policy for the state that has a huge impact on the rest of on schools and on all of these other domains, on the community, relational, and individual domain. And we can move forward. And this is explaining in more detail that all these domains do not live in a vacuum either. You don't focus on just one. They tend to interact with each other. If you change individual behaviors, that can affect communities and relationships. If you change policies, that can affect all of these different domains. So they, in many cases, understanding that this doesn't happen in a vacuum, but multiple levels and systems can be impacted by this, and understanding that this is interdisciplinary, it's reciprocal, it's dynamic, and it's complex. And so trying to impact individuals and community behaviors and trying to change society is a big goal, but it can also, when thinking about it in this way, it helps us to frame our interventions and preventions better by who is our target population, what is a community, how are we defining it when we're trying to say we want to do community welfare or community health, like what does that look like, and helps us define our terms and target populations better, but also be more effective at I'm blanking on this word, but assessment and evaluation. Okay, we can move forward, sorry. Okay, risk and protective factors are a framework we like to use because they tend to be very useful in truly understanding this. We can move forward. Risk and protective factors, quickly defined. Characteristics that increase the likelihood of a poor health outcome or behavior. One of our, I'll shout out to Tooele County, one of our public health people there and community prevention folks said that they like using the term vulnerability factors and resiliency factors. And we thought those were good terms as well, because in some ways a risk factor means it sounds like a person's taking a risk, when in reality it might just be that the community or the situation or the environment they're in makes them more vulnerable to poor health. Right? So vulnerability, we just like the term, so we threw it in here to say it's a good way to think about it too, to remove some of that stigma. Protective factors are characteristics that decrease the likelihood of a poor health or behavioral outcome because it provides a buffer against risk, otherwise known as resiliency factors. And we'll talk about resiliency in a couple minutes as well. But these are ways to think about this, is like, what are things that are influencing negative health outcomes? What are things that are influencing positive health outcomes? We use a very strength-based approach too to say why we should be focused focusing on risk factors. That's very, very important, but that's also intervention thinking as well. And if we're truly doing primary prevention thinking, are we thinking about protective factors? What kind of things already exist that keep us safer? And are we honoring and bringing those up and talking about them and highlighting them? Are we talking about the things that are working? Because as much as we need to talk about the things that aren't working, we need to spend some time talking about what is and buffering those and making those components stronger. We can move forward. Shared risk and protective factors. And this is where the kind of rubber meets the road in some of the work we're talking about here. We tend historically to be very siloed in our thinking about how we look at health problems. We deal with underage drinking. We then deal with suicidal ideation. We then deal with asthma and distributing medications in schools, and all of these issues we tend to deal with in little siloed areas. And what we started realizing in the Department of Health is a lot of these negative health outcomes share risk factors and protective factors. So the same things that put you at risk for underage drinking also put you at risk for depression and suicidal ideation. The same things that put you at risk for, or the same things that protect you from some of these things will protect you from other things. So in essence, if we look at some of these risk factors and protective factors and see which ones are shared over multiple issues, just by targeting those simple risk factors and protective factors, we can do more work on a variety of different health issues. And we can actually, so it's the concept of killing more birds with two birds with one stone, right? It's the concept of getting more done. And oftentimes it allows us, I work mainly in interpersonal violence prevention, so rape, sexual assault, stalking, sexual harassment, dating violence, domestic violence, that sort of thing. What we started figuring out was the same things that protect people from interpersonal violence, teen dating violence in schools, protect people from underage drinking and teen pregnancy. So they share many different risk factors. So if we tackle those risk factors, we don't need to target these specific areas. We can stop it from happening in the first place amongst a whole bunch of issues and use less resources. And there's a ton of value in this. For those interested in exploring these kinds of ideas of shared risk and protective factors more, the CDC's Connecting the Dots documents, which are free, you can just go to the CDC's page and download those things. I think I have links to them, or I can send you those. And Veto Violence's work, which is connected to the CDC as well, have really good resources with this conceptual idea of risk and protective factors. Okay, we can move forward. I'm trying to be cognizant of time. So also just understanding with risk and protective factors, they have an added effect. The more risk factors you have, the higher your risk. The more protective factors you have, the higher your protection and buffering from negative health outcomes. They're not all are created equal. Some risk factors have a deeper impact than others. So poverty as a risk factor has a much deeper impact than an environment of partying. So understanding these kinds of things, that they're not all equal and some can impact health more. We already talked about shared risk and protective factors, and understanding the most important concept here too is oftentimes when people see these, they think, okay, well, if there's all these risk factors, there's nothing we can do. But what we need to start thinking about is how do we buffer people and prepare them with resiliency training and give communities more resiliency protection so that they aren't as impacted as negatively. And I think Kuhn will give you some really good insight into this during his section on how you can buffer communities or with some early interventions. It's really neat stuff to think about. Okay, we can move forward. Just understanding what social determinants of health, we talked a little bit about it in terms of more people are at risk for health for a whole bunch of reasons associated outside their understanding. But when we think about social determinants, we're thinking about neighborhoods and built environments. Are they walkable? Are they safe? Are they connected to transit and maneuverability? Do they have of access to food and hygiene issues that they need? Economic stability is very critical and can have a deep impact on health and health outcomes and violence specifically. Health and healthcare access is really critical. Opportunities for education and resources, and also access to education in communities. And finally, social and community context. And what that means too is thinking like, are people feeling connected and safe and part of their communities as well? So when we add these components in, we start to see real strong correlations between negative health outcomes for entire communities and society. Okay. this is just an example of the Bar-High model that we like. This comes from the Bay Area Regional Health Inequities Initiative, but it's a helpful way to start looking at what we usually focus on. If you look at the last three points, the risk behaviors, disease and injury and mortality, that tends to be the thing we think about when we think about healthcare. But what Bar-High asks, and what we're hoping people start to do, especially in terms of prevention and early intervention, is start looking at those first three bullet points: social inequities, institutional inequities, and living conditions. Are those things we're focusing on, as well as those individual behaviors and disease and injury issues? Because what we find is behaviors, disease and injury, mortality tend to be outcomes. They are symptoms of greater health and community ills and welfare. And we need to start thinking about how to start shifting that, so we don't have to deal so much with the individual outcomes. We can start nipping it in the bud before it gets to be a problem. And then we create healthier, happier, safer communities, which is everybody's goal. Okay. We can go. And just understanding root causes. And again, this is that age-old iceberg thing, that there's a lot going on underneath. And so instead of focusing on just events, patterns, or behaviors, we also need to start thinking about structures, what causes these patterns and what causes them to be maintained. We have a lot of answers to this, and we have a lot of questions of why is this going on, or why does this work? And we're spending a great deal more time under the water right now, especially at the Department of Health, and trying to understand the structural inequities that are creating some of these poor health outcomes for certain communities in our state, in rural communities, in tribal lands, and even in some of our urban communities. Why is there differences in those places between health outcomes for people, and what can we do to interrupt that and provide better health for everybody? Okay. We can go forward. And then, yeah, again, just I'm going to move forward through this. This is just a better example of like what resiliency, the leaves you're seeing are the outcomes of either root causes that are harm and negative and family violence and history of violence, or you're looking at better connectedness, better access to education, more equity amongst on lines of gender and race and class, things like that. They have the fruit you want from that tree is going to be directly related to the soil it's grown in. So there's just a way to think about that. Okay, we can move forward. And finally, the last concept before I kind of start closing out is just adverse childhood experiences. I hope that many of you have started to learn about and understand. I hope that many of you have already seen presentations and have been exposed to the concept of adverse childhood experiences, or what we call ACEs. And we can move forward to the first slide. Adverse childhood experiences ask us to look at a few individual factors that can have deep correlation to long-term health outcomes. Just a really quick note on it. In the 1990s, Kaiser Permanente, the insurance organization, was doing a study on obesity, and they basically used a social work intake form instead of a medical intake form, which started to have them ask questions about sexual abuse, neglect, physical abuse, and alcoholism. And what they got from some of those questions was they started seeing incredibly strong correlations to long-term negative health outcomes and early death. They saw strong correlations to people, and we've seen this actually in the state of Utah. There are correlations between adverse childhood experiences and asthma as adults, risk of smoking long-term, risk of a lot of other kind of like culturally manufactured diseases or environmental diseases like diabetes, type 2 diabetes, these kinds of things. All of this strongly correlated to early childhood exposure to violence. And one of the other things we found with this study was not only did we see strong correlations to negative health outcomes, but when we intervened on the level of these issues of neglect, abuse, and household dysfunction, we also started seeing an immediate shift in better health outcomes for those folks. So it's not just that if you had ACEs, the world is ending and you're never going to get better because you had these bad experiences as a child. But if we address those experiences and start to provide services, support, and treatment, all of a sudden you are as healthy as anybody else. So, but understanding too, like, if we, in many cases, especially with the schools, understanding how ACEs function and work is really critical, but it also starts to explain in some cases behaviors and violent behaviors or antisocial behaviors, which Kuhn's going to talk about in more detail and better detail than I in a minute, that like understanding those is really critical. And that's how we start. But understanding like they didn't come from nowhere oftentimes. And if we ask a second question or go a little deeper or go farther upstream, we get answers and understanding and then build empathy on that, which is really powerful. Okay, we can move forward. This is just long-term effects of ACEs. Understanding too, obesity, diabetes, depression, suicide attempts, all are increased with the increase of the number of ACEs or childhood adverse experiences you have. So it has significant impact, but when addressed, it can also be reversed quite quickly. Okay, move forward. And by the way, just for on note of ACEs, if you are interested, I know the health department and a bunch of other agencies in the state have like long-term trainings on ACEs. Please invite these folks to, and I can help you locate the program you like with the agency that does it that you like. But like, please invite these this information into your schools with teachers, faculty, administration, so they understand these things better. They are very useful tools in our tool chest of combating some of the barriers to success for students. So just one man's opinion. And then understanding just social norms, values, beliefs, attitudes, behaviors that impact people's health or health outcomes. These can, and one of the things when we talk about social norms and their impact, understanding that some social norms can be protective factors and some social norms can be risk factors. So being thoughtful about that. I always give this example when I used to work at the University of Maryland, and they had a campus bar that was like a terrible kind of meat markety campus bar right off campus. And they had an event at this bar, or they had a campus ritual that on your 21st birthday, you would drink 21 shots or 21 shooters technically in 21 or that evening. So on your 21st birthday, you would attempt to drink 21 shooters. Those are drinks like kamikazes or hurricane, things like that. This is not a good idea. This is a very unsafe, very scary thing to attempt. Many students would do this. I even worked in their student health center, and I had student volunteers and like student health educators who would participate in this because it was such a normal campus cultural thing to do. So students would come in on a Monday morning with like hash marks on their arms for how many of these drinks they got through. Very scary. And almost nobody got to 21, and many students got very sick and some got hospitalized. I'm sure before I got there, some students died from this attempt. Very, very scary. And what we started thinking was, this is a bunch of these students would probably try this, but a lot of them wouldn't if it wasn't a culturally normal thing to do. They had created an event, a rite of passage for this campus that now instructed many students who would never have even thought to do it. So we started talking to students. We started doing advertising. We started talking to the bar owners. We started talking to the administration and about their relationship with this bar and how we might start to utilize that to change this kind of campus culture and ask them to stop doing this because it was causing harm. So again, an example too of something that had it not been a belief or a social norm in this community amongst this population, less people would have done it. So finding these things out and addressing them is critical. Okay, we can go forward. And again, social norms influence behavior. Norms are often misperceived, over or underestimated. So oftentimes you'll see this. Everybody at the school, because there's partying after a football game, thinks everybody parties. When in reality, we know that most people oftentimes don't, or don't abusively drink or excessively drink. So maybe we should start changing and shifting that idea of what is the reality. Misperceptions encourage people to conform to false norms and conform to what is incorrectly perceived to be true. So correcting misperception allows individuals to act according to their own beliefs, which are most often positive and consistent with prevention goals. So understand too is most people, even young people, want to do the right thing most of the time. And we need to remember this and believe this, that is the goal. And so we want to reinforce that is a normal cultural thing to do. In our community, our clan, our tribe, our people, this is what we normally do. And so this is what's healthy. And of course, you're going to have outliers, and that's where Kuhn's going to come in a minute here and talk about how you deal with those outliers who do the unhealthy thing or the violent or dangerous. We can move forward, Kuhn. These are just a bit of references. What I was hoping to do here is kind of lay the groundwork for how to globally or more structurally think about our interventions, especially our individual interventions, that we're going to spend some time talking about how those interventions should take place, but how you can use some of these additional skills to do that. When Kuhn and I spent some time putting this together too, it was really neat to just see how some of these efforts at our level at the Department of Health were really melding and braiding uniquely with some of the efforts at the State Board of Education. So with that, I will turn the time over, and I will be ready to answer some questions with Kuhn after.
Well, thank you, Marty, for your presentation and providing that overview look at a whole as a students, right, and their health, and get into the focus on their well-being. In terms of what I will bring to this group is a little focus when in the classroom portion of our class is the building a culture of change within our classroom. The work that I share with you is from the International Institute for Restorative Practice, which I just got certified to train and provide the information and share with you today. So part of the or IIRP, the founders believe that human beings are happier, more productive, and more likely to make positive change in their behavior when those in the position of authority do things with them rather than to them or for them, right? And so the collaborative, I share with you this perspective, I'll be there and work with you and to achieve that. So in that regard, restorative practice is the new framework just recently introduced. I mean, this has been around, but I think this come along to use that stable education and to a classroom recently, I think, to my knowledge, probably about 3 years, 2018 or so, with the House Bill 239 Juvenile Justice reform, and talking about how do we keep some of the school behavior at the school level and how can we address them. This is one of the many options. It's not the only option, but one of the many options. And we're looking at the guiding principle of restorative practices, right? Everyday interaction with youth. We're looking at faculty and staff and looking at the experience. This is a mind shift change and the framework going forward on how you think to deal with and the approach that as authority figure to the student and to work with student in that framework. So it's a mind shift. Is to maximize the time the students are in school and how can you teach and learn, share the knowledge to them, and how can we foster a healthy relationship so they can learn. Building that relationship with Marty mentioned earlier, building that strong connection relationship. Again, mindship. This just to share with you, restorative practice is not a program per se. It's not like a program A, B, and C that you do, but a mind shift and a framing and thinking and approach to deal with this behavior. And this is everyday practice. That's hence the word practice, and that what I'll be sharing with you. In terms of the restorative practice, a lot of it is building, in a nutshell, RCA, relationship, community, and accountability. What is a relationship? In terms of teacher to student, right? A teacher to teacher, teacher to school admin, and then what are beyond that relationship, right? The relationship for the student who with the personnel at the lunchroom, right? The custodian, secretary, those are all part of that. What is the relationship for that student, right? When the student first walked into the classroom to the school, do they feel welcome being in? And that's the connection. And when a student have that strong connection relationship, then a lot of things can happen in a positive way, when we have a positive relationship. The community is relations to a fifth grader communities, right? Within the students, or within that class, do you build that strong community and connection within that all 3 or 4 of those fifth grader classroom? Do they have that connection within that school, and the teacher work together and build that community? And as we go further, and I say earlier about the relationship and the community between students and the teacher to parents within that community, with all those parents. So how are you connecting and build that community relation? And all of that to say is that we looking at accountability when we have a positive relationship, and then calling when student have an issue or misbehave at school, we have that connection and call them out and work it out. We don't just like, okay, our relationship, we keep our youth accountable for the behavior, but it's not necessary in a punitive way. And to go to that, we had to make that connection at the beginning on the relationship and community. And as we move forward, keep them accountable for the behavior is much easier. In terms of the fundamental discipline in the IIRP is on the social discipline window here. What you're seeing here to the left is the control, setting limit, setting discipline strategy, or the word that I would like to use and it's easier to understand is setting that expectation. Low expectation to high expectation. And then on to the, as you move to the right, low support to high support. So when we have a low support and low control or low expectation of a youth, right? And then that's called the not or neglectful. We don't, for the not neglectful is low control for the environment, the structured classroom, provide no support help. So when a student misbehave, the teacher ignore the behavior, if you will, and wish and hope that a principal will walk by or someone else will take care of them, or that problem will go away. So pretty no support, no expectation in that classroom, and that's the not. When we go to the punitive setting, which is on the right upper, I'm sorry, the left upper, the two, right? Is when a student conduct a misbehavior, a teacher has a high expectation that this is not something you do in my classroom, and then right away would be go stand in the corner or some type of punishment go right away for that misbehavior that you shouldn't behave it that way. This is your consequences. So give the consequences right away, right? Sit down, no talking or whatever the consequences that the teachers have. There is no support into how the students should behave, right? And so that's the punitive. And we go to the for or the permissive. This is when a student misbehaves, the teacher will give excuses for the behavior. A student came in from the, oh, the student must have a hard day at home, or that the student from the must have a abusive family, or some sort of excuse for to allow for students to misbehave in the classroom. And that's where you have permissive, given high support for student, but no expectation at all. In terms of the where we want to be, is to promote in everyday practices to the with or restorative practice. This is where you give a high expectation or clear expectation for our student. At the same time, a teacher, a person of authority, give that right support and resources to support students to achieve that expectation. And that's the high control in the classroom also provide support skill to help students achieve the expectation that what are the expectation that is set for that classroom. And so in that framework, this is how I like to demonstrate. And I got this from my cousin. I don't have the due credit to where this picture come from, but it illustrate the behavior, right? In military, where is very commanding order, this is what you expect it to do. So that's illustrate the punitive approach there. The lower left here, okay, neglectful as a student in the classroom or as a kid in the house. Okay, you do whatever you do, I do whatever I need to do, and then just each person on their own way, right? um I mean, I fall into the permissive, the lower right hand corner there. If you are parents, have you ever had you feel like your kids is just driving the day's agenda, right? And they're asking for more. Can I do this, can I do that? And say, oh, I have a hard day, can I have that candy? Or that I haven't had my ice cream yet, and then dinner is after 7 p.m. and then they get ready to get that sugar up and want to eat that sweet thing, right? And at time we have that experience, and you know, working from home and kids at home, I have a 10 and a 12. I know that experience and try to, okay, uh, we set the rule on, okay, you need to complete your homework, you need to do your reading, and you will have the rewarding little tab on your computer, or that you can have go out, have a play, or then you can have that ice cream in the afternoon rather than 7 p.m. at night, right? And so that the framework in terms of clear expectation, giving that right amount of support in the classroom, and then working with an everyday reminding of that. That's the restorative practice that we're talking about. So it's not like a program per se. I mentioned earlier, right? That how do you do that? This is an everyday practice with that mind frame, creating that culture in mind as you move forward. So I like this picture a lot. It's illustrate what I just said earlier. So in that framework, what we encourage is that, is it fair? So how does that, do we engage our student in discussing those expectations, right? How do we engage and come up with those reasons? Why are you setting the rules that come to class in time? You have to be in class on time. You know, some kids may not associate with that, but if we say a reason that when you come on time and the minute you're in class is the minute to learn. And so, every student has to do that. We are doing that. So give that engagement and explanation for the reason why those expectation or rules or norm that you set in classroom, and engaging the student to set up so that everybody have clear expectation, and when somebody not follow that rules or norm is easily call out and then explain. So again, engaging students, involving them in those discussion, give a clear explanation of why those things happen, and a clear expectation for that everybody has to follow those rules in the classroom, and why is it good for everybody, right? And we'll likely get more you a positive result and the expectation that everyone be set for that classroom. As we go forward in this, just a reminder, we want that everything to be proactive. Part of the prevention is be proactive in addressing that. So we use in this restorative practice continuum here is from an informal all the way to formal. Some of us will understand a lot of times that restorative justice is another word that going around in the community. And then a lot of people is thinking about the circle, which is the formal conference. We work in that formal conference, but there are many aspects at the front end, talking about this continuum, starting out with the informal, and this is where we want to be, is like an effective statement. So when a student misbehave, we teach them to say, for example, two students hitting, one gets hitting the other. We'll say, when you hit, you call out that behavior, hitting is not okay. And then the effective statement is, when you hit me, this is how I feel. And I want to ask you to do it differently. So that's the effective statement that you call on that behavior, and teaching the youth how to express them immediately, including their feelings and how they want to change that behavior. As we move forward, and then affective question is another thing. When the students misbehave, we will want to asking, rather than why you doing that. And we know that some kids just, that's just they do. They may not be able to explain why they do that, but we ask them what happened. So then we started thinking for the youth, for the student to think internally, look internally. Oh, what happened? Why, not the why, but in terms of what did what did you do? Did you realize what happened? How this is affecting other? And what was the hardest thing for you when you doing this, right? And so we want to ask these students to think about what happened. Um, who do you hurt by doing this? Did it hurt you at this time? And what can you do differently? So strategically asking that question, and have the students think of their behavior. The same thing with the small importune conversation. So using that effective question, when you see two kids fighting, to see who go down the slide first at that playground, right? And that's not okay behavior. We call them out, we ask on both sides, and then help them resolve those issues right away at that level. Another thing in the circles is a proactive process for building a community or intervention strategy to address problem or building relationship, right? We mentioned about it, maybe there's a fire, a group of students within that classroom tend to go to class late, or that they don't turn in their homework, or that you can talk about the successes, how, so you form that group, everybody have a chance to have that conversation, and that's where you both problem solve and build a community. So that's a very informal circle, and it is a easy to um, apply in the classroom with not a lot of time. You just dedicate and intentionally dedicate a 15-minute classroom on every Monday or Wednesday to build that relationship, to create that class norm, or set an academic goal, or addressing a behavior problem within the classroom, engaging student in that conversation. And then the formal conference, which is we want responsive to those behavior, right? And we want to be only maybe focus on about 28% of our time is on responsive to behavior. A lot of time is to be proactive and preventing those misbehavior to occur in the first place. But back to the formal conference is when harm has been done on that behavior, consequences need to come out, and how can we make it fair. So then this is the you need to have a dedicated staff to coordinate, talk to the one who committed the misbehavior. We need to talk to the victim, talk to the parents on both sides, talk to the school admin to have an agreeable term. And then you call a meeting together, and a staff is to facilitate and moderate for that conversation occur, and then all parties to have to agree on that term, right? And then you have to have a follow-up to make sure that those agreed term will actually carry out. So that's where the formal conference take a lot more time, and that is a reactive to a behavior that is already committed and a harm has been done. But if we focus at the front end and everyday practice on the proactive preventing, building that relationship, building that strong communities, and also share that expectation that misbehavior in this classroom or at the school level, there will be consequences, but it's not a punitive, right? A day the student is not in classroom is a day that's not learning. So we want to keep our students for, low level school issue behavior at the school level. And this is one of the option. I won't be going too much in the introduction to circle, right? Circle can be used for a various reason and with various purpose, and just need to set a clear explanation and the purpose of the circle. It can be used for check-in, check-out, building community, can solving problem, repairing harm, and then of course the formal circle is one that I just explained to you. So if you will, in a nutshell, that is a restorative practice framework. And as we go further, this is a 32 hours training. I think I could train it down. I think I can work with a school district on the 8 hours, and it can be breaking into, an hour and a half or 2 hours segment, and go sequential, so that you don't have to learn it all at once. But a lot of this is a mind shift, a framework, and approaching a different angle to look at addressing school behavior at the school level. That concludes my presentation there. And this is, you can find more information at IIRP.edu. And then for us, if you want to contact, sorry, this is Cường Nguyen at school.utah.gov, and our prevention's website. We have a list more of topic that will provide either directly, or we have a vendor in place that can provide training to school, but you do have to submit a training request form that's very easy to fill out, but is initiate the conference training to start. So that's on my part as the USBE, and then there's Marty contact information. Anything you want to add, Marty?
Just open to answer questions. It's funny. I always feel like whenever we do these trainings, I just invite people to go to more trainings. Like, hey, here's an hour on how you need 10 more hours.
Oh, there's another 8 hours, yes.
Yeah, exactly. Well, and again, I mean, it's interesting to me. Like, I think there's so much new stuff coming out, which is great, but it's trying to balance that out with how much resource you have personally to to stay on top of things. So yeah, you need a team of people to send them out to different trainings and share. So.
All right, thank you both so much. We'll open the chat at this time for any questions. So if you have something you would like to ask either presenter, feel free to drop that in the chat and we'll read it out loud for the group. Okay, first question. Can we get a copy of the presentation?
For me. Yeah.
Yes, I would just clarify, because it's copyright, I just need to clarify a few things, and then most of the content you see as a PowerPoint, yes.
So if I can interject, this is Shalise Oldroyd. I'm support staff here at USBE and helping with this. So if that is cleared that we're able to share this, it would be posted on our events and trainings page for you to then access it there. And same if with the recording, if we get clearance for that copyrighted portion, the recording would be posted there as well.
Hey, thank you, Shalise. Another question we had is USBE able to do live trainings yet?
Christy, you may know this.
I'm happy to interject. So I'll start. Yes, we're able to do live trainings. We have a training request portal in which you would enter your information, what school you're from, what topics you're interested in. And we review that as a leadership team, and then it's assigned to the appropriate personnel. And so Shalise, I don't know if you have, oh, she reads my mind. So the training request portal, which is the TRP, Shalise just dropped into the chat. So feel free to copy and paste that. It's also at the bottom of our email signatures. So if you have any emails from folks in the student support section at USBE, it is also attached at the bottom, and you just click on it and fill out the information. Also, Kuhn spoke a little bit about his recent training in restorative practices. And so Kuhn could also possibly come out and train. Is that correct, Kuhn? That's a plan.
Yes, I am certified now. So I, if the request to the TRP there in terms of restore practice, then it will come to me, and then I'll coordinate with the requester and plan for that.
And then your Department of Health friends are also great resources. Marty, do you want to speak to that a little bit as far as getting folks out from violence and injury prevention to support some of these trainings?
Yeah, I will say we, so the state is open from the perspective of COVID. So we are, although we're in process of doing some shifting structurally. So I'm like just making sure we give a little bit, a decent amount of lead time to make sure we can provide the best training and precisely what folks are asking. But yeah, we're now starting that process of being able to go and do in-person trainings. Is that, I'm wondering if I'm answering the right question. Yeah, I got confused, but yeah, we are. It's funny. I'm trying. I know that we're just like trying to reshift now into opening up again. We're in the process of doing that. So I don't want to promise people anything immediately, but in the very near future, we can probably start gearing up and coming to places in person.
Perfect. All right. Yes, go ahead, Ken.
Oh, just clarify on the one of the questions say about live. I was thinking about, is the link live or that we can be live in person training? Just clarifying USB, we are set we are scheduled to be back in person partially starting July 1st, in terms of able to meet with in person and provide training. That would be something, if you can answer, Chrissy, or do you know more of that yet?
So right now it's by permission. So
Okay.
if a training were to be scheduled, that would be something just to run through leadership and make sure we're okay to come out and do that depending on the time frame. So the TRP really is the best way to get your request answered. So,
and we can always do virtual.
yes, absolutely. Absolutely. So another question from Paul Murphy. Thank you, Paul. Cultural norms are very interesting as they are norms, but not true of everyone. Are you aware of any resources that list some of the more common norms?
It's a really good question. And I think the person asking the question framed it really well too, that they're also situational and somewhat connected to communities themselves. This is where components of cultural competency or cultural humility, depending on how you frame that, comes into play, that you want to make sure that this is something we have to do a lot at the State Department of Health, is making sure that not only is our material factual, accurate, and scientifically based, but that it also meets community standards and community expectations in that moment. So my short and kind of simple answer is always working with the populations to make sure that that community standards are being adhered to, while also sort of working with people within those communities to say, how can we push some of these boundaries? Because some of the topics we've all been talking about even today, discipline, violence, even my area of interpersonal violence, are uncomfortable and awkward, and there's no way to get around that. So how do we make them more palatable or easier to talk about? Is really critical. But I like the idea of spending more time figuring out this is such a great question too, because cultural competency is also different between different ages. That like the cultural competency talking to 14, I have very low cultural competency talking to 14-year-olds. They don't take me seriously, right? So I know that. So how do I, arm myself with other young folks who can interpret or maybe give a message better, or with faculty and staff from their schools that are respected and who they listen to and so who they trust. So I don't know if that totally answers your question, but I think that it's always got to be an ongoing question. I don't know if Kuhn has a.
I agree with you, Marty, with culture, norm, and all of that. Has to consider local context, right? The culture context of where we go and work with, the urban classroom versus rural classroom might be different in that regard. So part of the building relationship, we didn't go into that detail, but then part of the discussion is talking about how is those relationship with students or with parents, or how does it feel like, how does it look like, and how it sounds like. And we go into that, and how you connect and raise the expectation at the home relationship, parent and kids, and the conversation versus in the classroom, and how kids tend to talk more or talk less, can have a factor in how they behave in the classroom. And so we go in more in depth, but it's not like a set in stone, so that has to be in considerate part of the discussion, and taking local culture context as part of the discussion.
Okay, good. Thank you. All right, this one is from Tammy C. How do you teach parents about restorative practices? Some state restorative practices are permissive practices. Sometimes in our district, the parent won't allow the school to use restorative practices and pursue legal action. We have adjusted policy to be trauma informed and restorative and would like to mitigate this.
I think asking parent involvement is the $1 million questions, right? I think how can we do that? I think there are some standard outreach, parent night and all of that. I think the involvement in building that relationship and outreaching to building that community would have to come down to the school level and then the classroom level, taking that initiative on the creating that culture climate that parents' involvement is critically important and involved and then share this training. I don't per se have the answer. I just can see that this can be, we just need to do outreach and share this practice with parents. That's my take for now. I wonder if Christy, you have any other thing, or Marty, if you have anything to add in terms of parent involvement.
I think it kind of goes in conjunction with the last question too, of you know, cultural competence and comfort of parents with those topics. You know, for us, when we are in communities where there's a little bit of apprehension for certain topics or programs, we find it really useful to work with communities of care coalitions or PTAs or other agencies that will give us some buy-in or will give the community a sense of trust with what we're doing. And, you know, I think in some ways, COVID was such a great example of this too, of asking parents to do things outside their comfort zones and skill sets in terms of educating and working full-time and home and being a full-time full-time parents at home during the day as well. So it makes me think that you like what kind of skills and resources and educational aids can we provide parents for these continued discussions at home, because it is so it's such an interesting with a lot of what Kuhn said, it's so ongoing. Like, it's not a question of like this one incident, discipline it, and it goes away. It's just not how life works. It's not how people work. So how can we provide support for caregivers and parents or trusted adults in a variety of different spaces outside of just that classroom? It's a really good question. Yeah, and you know, we're getting better and better at this, I think, by communicating with experts and kind of champions within communities as well. That like when I find my people regionally in certain parts of Utah, I often find myself going to them frequently with how to do this, how to frame this, and how to distribute it. So.
Okay, thank you both. And I think as a side note, restorative practices are all about communication and connection. And so listening to the parents and giving them a voice to their concerns, and then starting small with that tiny snowball, and then just starting to push it down the hill where more and more people become champions of the practice. I think sometimes that just understanding that if the water keeps rushing, the stones will move out of the way or they'll smooth over. And so just understanding that it is a process and working through stigmas takes time. So next question from Chansey. Kuhn mentioned having staff available to support circles/restorative conversations. We have found all staff need to have the training so they have the tools/dialogue strategies to model for students. Maybe a little bit more of a comment. Anything you'd like to add to that, Kuhn?
And no, that's
okay. Yeah, thank you for that comment. All right, Patty said, what successful interventions empowering families to deal with their ACEs have you seen? This is Patty Shea. Thank you, Patty.
I'm sorry, can you ask the question one more time?
Yes, of course. So what successful interventions empowering families to deal with their ACEs have you seen? So what successful interventions have you seen?
Yeah, I mean, that is a really good question. I would like to see more. I mean, I think right now we are in the early stages right now of educating folks around the state on ACEs, that the trainings that the state provides and I believe it comes out of the Department of Workforce Services and some other areas, have only been around since around 2019. And then COVID happened, so which was so disruptive to our kind of all of our processes and outreach that sort of shuttered So I would say we're in the process now of just teaching folks who need to know this stuff, what ACEs are and what to look like and how to start intervention practices. I would say working with social workers within your community to start to create spaces and places for both young people and people who've experienced ACEs to come and receive resources. You know, the connection with adverse childhood experiences is so important in terms of even looking at some of our most vulnerable populations in the state. When we look at our homeless population in various parts of the state too, or people experiencing homelessness, we know that the ACEs for many of the folks in those communities are extremely high. So in some ways, right now we need to do twofold things, which is continue to build better infrastructure to help people who have experienced high ACEs and then serious negative health outcomes. To me, this feels like it needs to be more structural and less like kind of family oriented. Your question's so interesting because my mind tends to go to more structural areas over kind of family interventions, which is more of the like individual or relational domains of that of the social ecological model. What I'd like to see is like, do we have resources broadly statewide for people who are suffering drug addiction and mental health barriers so severe that they can't function with employment or with it safely with their families. So did they have places and resources and outreach to go to medically or mental health wise that are affordable and that are accessible? Like these are those structures we have to start building too for the people with the most need. With families, to me, I think we need to start. It's a culture change and a cultural norms model of not destigmatizing these kinds of things. That it is not strange that somebody went through trauma as a kid. That is unfortunately all too common and normal. And so acting as though this is something like this person doesn't need to be coddled and swaddled and wrapped up and protected, but they also need to be supported. And we need to take those traumas seriously. That we tend to overreact or underreact when we hear about these kinds of negative childhood experiences and trauma. So how do we start to shift our policies and focus? To me, the schools are a great place to start because you can both catch ACEs while they're happening, but also help families who have experienced ACEs get to resources because you find them out. But it requires like those kinds of dialogues and discussions, like teaching young people about this stuff so they go and talk to their parents and explain these kinds of things so their parents can go, oh, this might be something that's impacting my behavior, my reactivity, how I feel every day, my depression, and I should go get help. I mean, right now, so that was a really long walk to say we do not have appropriate services yet to address your question. We need better ones, and we need to start working on a broad-based policy format and infrastructure format to make that reality. But on a day-to-day basis, like to me right now, we're in this kind of discussion and open talking phase. We need to start talking about this more. We need to make people more aware of these things, and that like searching out resources help and services for these is not a character flaw. It is not you're not a sick person. You're a person who needs help for an insurmountable problem that you did not cause yourself. So yeah, I don't know. I feel like I went off on a tangent there. We need better systems. We don't have them yet. I don't have good enough stories, but hopefully by within a year from now, we will have much, much better structures. And to me, I would say the homework is to go out and create that if you can. Like start to create this and call us and ask us for help. We also have a new huge grant at the Department of Health called oh my gosh, why am I blanking on this name? Essentials for Childhood grant. If you're curious about that, it works on social determinants of health, and ACEs is a component of that. And we're trying to create infrastructure for communities throughout the state to resource that. Joey Thurgood at the Department of Health is a great place to start. And I can give you her contact if you want me to. I can find that real quick.
Awesome, thank you. So we'll wrap up with these last two comments in the chat by Marianne Oborn. So the first one is, my experience with restorative practices has been very positive. It does take time, and this is probably one of the biggest concerns, is to make sure there's enough time to work through an issue. I love that the state is supporting this. Thanks, Marianne. The second one there is, my concern working with ACEs is that it focuses on childhood adverse experiences. Have you seen impact on adult ACEs and long-term impact there with, i.e. adults in abusive relationships?
I mean, so the answer is yes, and part of the problem with ACEs as a concept is the higher the number of ACEs, the more likely you're going to experience adult adverse experience. That like ACEs will continue the higher your trauma or experience was, and the more impact. I mean, again, I would really highly encourage anybody to spend some time in learning about this. What we know, even just about the like trauma to the brain associated with adverse childhood experience, it has the same impact of high use alcohol or drug use, where it stunts development and growth of components and parts of brain development for coping strategies and for reactivity and so like what I would love to see long term is that we are going through our jails and prisons and assessing ACEs and doing treatment accordingly, like let alone just our school kids and school-aged kids and their parents. That this is something that is, we are learning something very important right now about adverse childhood experience and childhood trauma, and so and to me that is where the rubber meets the road here. It's an opportunity to both start addressing childhood experience and then informing and providing adults with the opportunity that they need to go get these things treated as well. Like PTSD is a diagnosable disorder, which you can then get medical treatment and care for. And the more people who get diagnosed with it, who get that diagnosis, the better their care and access to care will be too. But we stigmatize mental health too. So we're fighting this never-ending battle of like destigmatization to get people to even start addressing it, and then building the infrastructure based on the need, because people won't go get the help and won't get diagnosed or won't address those issues. So then we don't create the infrastructure for it. So the more people that go and the more people we can inform about this and then create opportunities for them to seek services and support, the better the support will be. We'll start creating those systems. But yeah, I think your point, the point of that question is so good, that like we are not just dealing with children, we're dealing with adults. This is always something I say when I talk. I do primary prevention at the State Department of Health, and what I like with Kuhn in this presentation is we're also talking about early intervention, which to me is on the cusp of that primary prevention for greater violence or harm or health issues later in life. This is one of the things where we go, we're doing prevention and intervention at exactly the same time. We're not in a place where we can truly start talking about primary prevention. It's all going to be intervention with hopefully more prevention tossed in as often as we can. So yeah, I would say keep asking that question, especially as we start addressing childhood. Like, what are we doing for the adults of these children? What are we doing for the community members who are experiencing this? And whose job is that? And if that turns onto the state, hold us accountable. I know this is being recorded. I'm going to get in trouble for that. But this is one of those areas to me where we go, if the state is not doing its job, if the schools are not doing it, like, what do we need to do that? And this is not a slap on the hand to them. It's not, as Kuhn would say, it's not punishment. It's it's an opportunity to grow and learn and be better, just like we're trying to do for young people in this presentation. Like, if they're how can we make this better, and how can we keep doing better? But yeah, I don't think we're doing a good enough job would be my answer, short answer.
All right. Kuhn, anything you wanted to add? Any last words?
I would say thank you. And just the collaboration is really awesome. And as we hope to continue this moving forward and collaborate as we can. Thank you.
Fabulous. Okay. Thank you all so much for attending today. Again, watch for the links and the information on the events and trainings page. There will be more professional development opportunities in the coming school year, and we'd like to invite you all to join us then. So thank you all so much, and have a good Tuesday.